All right, let's talk about asthma. A lot of us know somebody who has asthma. It comes and goes with some other people. So, what is it? It's a chronic inflammatory lung response to a trigger, right? To an allergen, to a disproportionate immune response to a trigger, right? And it has different signs and symptoms. It can be unpredictable with periods of control and then periods of exacerbation, depending on the weather, your exposure to certain things, right? Depending on your genetics, so some people can inherit it. It's an immune response. So um, if you had certain infections earlier in life, um, like if you have a better immune system, you're going to be better at not having asthma. So if you have a poor immune system, you might have asthma because your immune system isn't as trained to deal with allergens, as opposed to somebody who has a better immune system. GERD can also trigger bronchoconstriction, so it could give you bouts of asthma, respiratory tract infections, nose and sinus issues, drug and food allergies, right? So how this happens is you get the trigger. The trigger is going to inflame your airway, and then that's going to do three things. So an inflamed airway is the beginning of the immune response. It's going to make you secrete mucus. It's going to constrict your airway muscles, and it's going to swell your bronchial membranes. So swelling, muscle constriction, and secretion of mucus. Okay, and all of these things come back to create the narrowing of breathing passages. Okay, so we have our secretion of mucus that's going to clog your airway. The muscles are going to be constricted, so you can't take that deep breath. And then swelling of brachial membranes. That swelling is going to increase the inflammation. All of these three things are basically making it more difficult for you to breathe. Okay, and how is that going to manifest? Like with anybody who's witnessed an asthma attack, you're going to have wheezing, coughing, shortness of breath, and tightness in your chest. Okay, so all of those three actions that are the result of your immune response being triggered are going to cause you to not be able to breathe effectively, right? So wheezing is the most common sign. It's going to give you a cough, dyspnea, and chest tightness. Okay. Now, what are the classifications of asthma? So you have intermittent, you have mild, you have moderate, and you have severe. Okay. Intermittent means it comes and goes. Okay, like intermittent suction, you have intermittent asthma. It comes, it goes. It's not really reliable. Sometimes it's there, sometimes it's not. Mild persistent is twice a week. Okay, if you you have asthma attacks twice a week. You have mild persistent. If you have moderate persistent, it's every week. Okay, you have twice a week or two or more per week every week. It's now moderate persistent. Okay, and if you have severe, it's more than that. So you could have it every day. You could have multiple times a day. So the classification is determined by the extent that the patient is affected by asthma. So that's number of attacks, what medication you're already using, lung function tests, and the number of exacerbations that you have. Okay. So what's one complication that we can think of when it comes to asthma? So with somebody who has asthma, when we're thinking of people who undergo these immune responses, one thing that they're going to do is they're going to increase the number of respirations in an attempt to oxygenate themselves, in an attempt to breathe, right? So what's going to happen when somebody starts to hyperventilate? Think of when you have anxiety and they give you that paper bag to use to breathe in and out of. That's for a purpose, and that's because when you hyperventilate, right, when you're constantly breathing out, your lungs are constantly taking in oxygen and you're releasing carbon dioxide. Okay, this is going to put you in a state of respiratory alkalosis. Okay, CO2 is inherently acidic. So what I'm going to do if I have an asthma attack and I'm trying to oxygenate myself, I'm going to go right. I'm taking those hyperventilated breaths. I'm releasing my CO2 into the air. I'm intaking oxygen. Now, what's going to happen is now my blood is going to be more alkalosis, right? It's not going to be as acidic, okay? Because I'm releasing an acidic agent. I'm releasing carbon dioxide from my bloodstream into the air, okay? And I'm taking on more oxygen. So that can be that can cause severe and life-threatening exacerbations, right? One way to see if your patient is at risk of respiratory alkalosis, check if the respiratory rate is greater than 30 breaths per minute. If they have shortness of breath at rest and feeling suffocated, their pulse is greater than 120 beats per minute, their PERF is 40% at best or less than 40%, and they're usually seen in the emergency room or hospitalized, right? So that's severe, okay? Life-threatening asthma is when they're too dyspneic to breathe, they're perspiring profusely, so they have a lot of sweat, they're drowsy and confused. So automatically, if they're confused, that tells me that they have low oxygen to the brain, could be a cause of low blood flow. But in this case specifically, it's an oxygenation issue, not a perfusion issue. Okay, so it's an oxygenation issue. They're having trouble getting air, getting oxygen into the blood because their blood is circulating fine. Okay, so if they're drowsy and confused, that tells me it's a severe asthma attack. If their PRF is less than 25% as well, then they'll be admitted to the ICU. Okay. Now, what's going to happen for our intermittent asthma in our treatment plan, right? So step one, they're going to give you a short-acting beta agonist. So remember beta, right? We'll write it down. So our beta is going to dilate. Okay, so BD, bad day, beta dilates. Okay, that's part of another acronym. It's ABCD. Alpha constricts, beta dilates, right? So BD, beta is going to dilate. Okay, so step one, they're going to give you a short-acting beta agonist. So SABA. That's going to be step one, okay? They're going to give you a short-acting beta agonist. Step two, they're going to add a low-dose inhaled corticosteroid. So they're going to give you ICS, inhaled corticosteroid. So what happens with steroids, right? When I give you a steroid, it's going to weaken your immune system. If asthma is an immune response issue, I'm going to give you something to lower your immune response, right? It just makes sense. I'm going to give you an inhaled corticosteroid to lower your immune system on top of giving you a short-acting beta agonist, right? So these beta agonists are going to go into your lungs. It's going to secrete that beta compound that we want, and it's going to tell your muscles to relax. It's going to dilate your bronchus, right? So it's going to dilate. Additionally, your immune response is going to be weakened. Okay, so the initial asthma attack itself won't even be as bad. Okay. Step three, they're gonna give you a low dose. They're gonna give you a medium dose of inhaled corticosteroid coupled with your SABA, right? Your short-acting beta agonist, right? Step four, they're gonna give you a medium dose of both. And step five, they're gonna switch you to, step four, they're gonna switch you to a long-term beta agonist. Okay, so short-term, think your albuterol, right? So your albuterol, that's going to be found in a lot of your inhalers, right? So that's your short-term. I don't need it long-term. I just need it for when I have my attack. Now, step four, they're going to switch you to long-term, and they're going to couple it with your inhaled corticosteroid. Step five is going to be a long-term or high-dose inhaled corticosteroid and your long-term. And for the step six, if you have really, really bad asthma, they're going to give you a high-dose inhaled corticosteroid. So you're going to have the steroid inhaled. Then they're going to give you a long-term beta agonist inhaled, and then they're going to give you an oral corticosteroid as well. Okay, so a whole lot of interventions based off of how severe your asthma is. Okay, so how are they going to diagnose asthma? So you have your pulmonary function test, your PFT, right? This is when they're going to measure the rate of airflow and estimate your lung size. Okay, so what's one thing we have to take into consideration before I take my patient to do their pulmonary function test, right? If my patient had a episode of asthma, right, and I maybe, as the nurse gave them one of these treatments, I'm going to want to stop their steroid before this function test. Okay, I want their raw results. I don't want something that's been altered by the medication. Let's say we gave them the medication, we gave them their steroids, and I take them to take their pulmonary function test. I'm now going to have a messed up answer result. I'm going to have a skewed result that's going to show me that my client is fine, when in reality they're not. They just gave me a result based off of their treatment when they've already been treated, right? So you're going to stop your steroid treatment 6 to 12 hours before their pulmonary function test. Okay, now you can also do peak flow monitoring. It's going to measure the maximum speed of expiration, specifically in 1 second. So forced expiratory volume in 1 second. They're going to look at how much air you can force out in 1 second. You're going to look at the degree of obstruction in the airway. They can also do chest x-ray. They can also do oximetry, and allergy testing is a big one. So they're going to see, hey, what's the trigger for this immune response? So they're going to do some allergy testing. Okay. Medication management. So again, you're going to use your short-term acting beta agonist, long-term acting beta agonist, inhaled or oral corticosteroids. So they're going to start inhaled. If there's no result or limited result, they're going to move to PO. They're going to go oral. Okay. A lot of the interprofessional care is revolved around patient education, environmental control, manage their comorbidities, and medication management, specifically teaching your patient how to use their inhaler. Okay. And that's what we're going to get into is drug therapy. So patient education. So correct administration is going to play a major role in how efficient the treatment is, right? So the metered dose inhaler, that's going to be your standard inhaler. You're going to shake, you're going to put your lips up to it, you're going to click down, you're going to take a deep breath and inhale and hold, and then you're going to release. For some people that aren't able to take that big of a deep breath, they're going to use a spacer. This is going to be my spacer, right? I have my inhaler. What the spacer is going to do is any medication that I'm not able to inhale into my lungs is now going to be stuck inside of the spacer. And if I need to take a second breath of the same dose, I don't need to dispense another dose. I just inhale that spacer one more time. Okay? So that's going to improve your inhalation. Actually, a funny story that I don't know where I got it from. So I've heard it at one point. So a lady has asthma and she goes to the doctor and she tells him, this medication doesn't work. You're a bad doctor. I've taken my inhaler several times. It doesn't stop my asthma attacks. And I'm upset with the treatment that I've received. So what the doctor does is he tells her, okay, well, let me see you show me how you use your inhaler at home. So she takes her inhaler and she shakes it and she goes, see, look, 1, 2, 3, 4, and it doesn't work, right? So of course, when you're doing drug therapy, you need to make sure your patient knows how to use their drugs, okay? So you have the dry powder inhaler. That's going to require less dexterity to use. And then your nebulizer. Your nebulizer is going to come in a liquid form. You're going to put it into a machine that's going to heat it and turn it into a vapor. And then they're going to inhale it using the mask. Okay? Let's see. So now let's talk about our drugs for asthma. So now you have quick relief, right? So quick relief sounds a lot like short acting, right? So quick relief, short acting beta agonist, right? So these are going to be your step one defense. The prime example is going to be albuterol. Albuterol. That's going to be our quick and easy one-step solution for those mild asthma attacks. Okay, so short-acting bronchodilators are used in acute asthma attacks. Another one of these, the other names are going to be ProAir, Ventolin, or Proventin. Those are all other names for albuterol. Relieves acute bronchospasms by dilating the bronchioles, right? Onset is within minutes, and it can last 4 to 8 hours, okay? Stimulate the beta adrenergic receptors in bronchioles, and it produces bronchodilation. It increases mucociliary clearance, so it allows you to cough up secretions a lot better. Remember, increased mucus secretions is one of the ways that asthma prevents you from being able to oxygenate, right? So this is going to allow you to clear your mucus secretions better. Must also be used with caution for people with cardiac disorders. So remember from last week, we were on beta blockers, right? We're on beta blockers. So if I give a beta blocker that's non-selective to an asthma patient, and then I give them albuterol as their medication, they're going to cancel each other out, okay? So my beta antagonist, my beta blocker, is going to cancel out my beta agonist. So my patient is now going to have an asthma attack. They're going to take their inhaler, and they're still going to be suffering and not being able to oxygenate because we gave them a beta blocker. Okay, so make sure if you're giving your client an albuterol, okay, make sure if they are a heart cardiac client with a heart condition, their medication is a selective, right? We want beta 1 beta blocker, right? We need it to be selective. These short acting are not for long-term use. Remember, 4 to 8 hours, okay? Now we have our persistent asthma daily medication. Now this is going to be a low-dose inhaled corticosteroid, right? So ICS. Now this is our first line of defense for new asthma, okay? If you have a new onset of asthma, we're going to start you off on an ICS, low dose, okay? This is going to be your fluticasone, right? Fluticasone. Say that 3 times fast. It's your corticosteroid. Another one is beclomethasone. Remember, they end in "-one". Fluticasone, right? Beclomethasone. Okay. So the first line therapy for persistent asthma must be taken 1 to 2 weeks before therapeutic effects. Okay, so if your client comes to you and they say, I've been taking my beclomethasone for 3 days and my asthma is still persistent, well, you can tell them that it takes 1 to 2 weeks before it becomes effective. Okay, now this is going to suppress your inflammatory response. It's going to suppress your immune system. Inhaled form is used in long-term control, systemic form to control exacerbations and to manage persistent asthma. So what this is going to do is essentially take out the problem. What is the problem with asthma? It's your oversensitivity, your immune response to an allergen. So what they're going to do is they're going to take out their immune response. They're going to weaken the immune response. Okay, this is going to reduce your bronchial hyperresponsiveness, decrease your mucus production. It's taken at a fixed schedule, and it can cause oropharyngeal candidiasis, hoarseness, and dry cough at the local side of the inhaled drug. Okay, so what this means is this also has side effects. It can cause candidiasis, which is your fungal infection. Again, it makes sense. It's going to weaken your immune system, right? These side effects can be reduced after using a spacer, so not taking the entire dose at one time, or you can gargle with each use, okay? Newer medication like cyclesinide activates in the lungs instead of in the pharynx, and it minimizes the side effects, okay? Now, other alternatives You can use receptor antagonists, right? So leukotriene receptor antagonists. Now these are going to block leukotrienes, which are bronchoconstrictors. So we're going to stop the bronchoconstriction from happening by giving these medications. They have both bronchodilator and inflammatory effects. They're not for acute attacks. So these are for long-term maintenance, used for prophylaxis, okay? So that's our alternative for step 2. Step 3 is the persistent asthma not controlled by low dose ICS alone. Okay, so now we're going to start combining medications and forms of treatment. So we tried step 1, which is our short acting. We tried step 2, which is either the leukotriene or the low dose inhaled corticosteroid. So now we're at step 3. Step 3 is going to be the combination of drugs. So we're going to combine long-acting beta-adrenergic receptors, LABA, and the low-dose ICS. Okay, so these are your salmeterol. Okay, salmeterol is your long-term. Okay, so salmeterol long-term, albuterol short-term. A comes before S. Know that. Albuterol comes before salmeterol. Okay, A before S. Okay, now this is combined. Salmeterol is going to be combined to your daily ICS. It decreases the need for short-acting beta antagonist because we already have a long-term acting one in place. It's not used by itself. It's never used as a monotherapy. I'm never going to give you salbuterol and kick you out the door. I'm always going to combine it because that's how it's best used. And it's for moderate or severe asthma. Okay. Now, I'm not going to go and mix my inhaled corticosteroid with my long-term acting beta agonist. These come in combination meds. Okay. Advair is a big one, right? So that's salmeterol and fluticasone combined. Or you have Symbicort, which is budesonide and formoterol. Okay, so know those two, Advair and Symbicort. These are the combinations of the two, right? You're not going to go in and start mixing your own long-term acting and inhaled corticosteroid. Okay. More convenient to use instead of giving 2 separate inhalers, they come combined, right? So it's going to increase your compliance. Okay. Remember, this all works as long as you educate your patient about how to use their therapy. Okay. Therapeutic outcomes, they're going to learn to control or eliminate their symptoms. You're going to find normal lung function. We want them to be able to resume their activities, reduce or eliminate exacerbation and side effects of medications. That's our therapeutic outcomes. Okay. In long-term avoidance, we want to avoid triggers, and we want to avoid like exercise-induced asthma. That's for persistent asthma. Okay. So our moderate exacerbations, you can give 2 to 4 puffs of albuterol every 20 minutes, 3 times to control the symptoms. The gold standard is short acting, so albuterol. Remember, so moderate exacerbations, you can give 2 to 4 puffs every 20 minutes, 3 times. Okay. Let's see. And again, you can always put them on oxygen. You can do O2 therapy, especially if their O2 sat drops below 90%. Okay. Let's see. You also want to avoid triggers, so dust covers, the cold air can also be a big trigger, so wear a mask or a scarf. Avoid NSAIDs as well. Increase your fluids. Why are we increasing fluids? Because we want to thin our secretions. We want to increase exercise always as tolerated. We don't want our exercise to induce our asthma attack, but we always want to have our client exercising as tolerated. We want them to maintain their nutrition. We want them to know when to seek medical attention and to measure their peak flow daily and to keep a journal of how they're feeling.